Awesome. Thank you, everyone. Again, I'm so excited to be part of this panel. As well as being a support and engagement coordinator for T1 International, I am also a registered anesthesia practitioner in the UK and a registered nurse in the United States. And I'm currently a public health scholar at Imperial College University in London. So, what brought me to advocacy was my experience when I transitioned from the UK to the United States for grad school and not having health insurance for about 6 months and having to borrow insulin from friends to survive until I was entitled to health insurance again, which really sucked. And I just couldn't imagine how like people around the world are going through this. In this session today, myself, Danny, and Lauren, we'll talk about trauma-informed care and how we can all as a community identify signs of trauma and include this in our advocacy effort for all affected by diabetes. I thought it would be really good to start off with seeing where we are with what we think trauma is and trauma-informed care. And so I will be giving one example and having us comment in the chat if we think that it's a good example of trauma-informed care or not so good one. And does that sound good to everyone? Okay. So this is scenario one. So Tammy is a 25-year-old woman who has been feeling unwell in the past few weeks. The nearest hospital to her home is quite some distance, so she decided to check in to a local urgent care center. Despite unknown cost of out-of-pocket treatments, when she arrived at the urgent care center, she was asked a number of questions about her health history. Tammy listed out health conditions that she currently has, which included type 1 diabetes. The healthcare professionals taking her health history responded, "My goodness, you have so many health problems, and you're so young, you have to do a better job looking after yourself." So what do you guys think? Is this trauma-informed care? And yep, the answer is no. Thank you all for participating. Tammy is experiencing a traumatic event and she has expressed her concerns and sought for help. And as a support system, healthcare professionals, friends, and so forth, it is our responsibility to try and provide a safe environment for her to share and receive support. I know that trauma is such a huge and sensitive topic in the diabetes community and generally, and I just thought that it's something that we need to talk more about. So what exactly is trauma? So trauma is basically an experience that disrupts our sense of safety in the moment and majority of the time, way after the event. And so in other words, trauma is the opposite of safety. So when we are working with or advocating for people who have experienced trauma, it's important for us to first establish safety for them. And this includes physical, psychological, and emotional safety. And alongside safety comes many more important principles that we're all going to talk about during this presentation. And I'll pass on to Danny and Lauren, and I'll come back at the end to test our knowledge.
Hi, everyone. I'm just going to share my screen here. Here I go. In regards to trauma and diabetes in itself, as much as in the other topic was being talked about, there's also important to talk about to understand the impact that diabetes has on mental health. And it can present itself in various ways, such as burnout, distress, and depression. And today, I just wanted to take a moment to share with you about this. I saw a lot of you talking about this in the chat. And before we start, I would love to see if you would like to share if at some point you have felt something in regards to burnout or distress in regards to yourself living with diabetes or someone you love living with diabetes. And I would love just to if you could share it in the chat. But why is it important? When I was growing up with diabetes, no one ever talked about this. No one ever said you might also have to take care of how you feel and how your emotions are, how you're thinking, how's your relationship with your condition. No one ever said that. Currently, it's being talked a bit more about it, but it seems that not enough. So it's important to me that we as advocates start asking ourselves, why should we be talking about it? Why is it important when we live with diabetes? Why is mental health and should be mental health part of our multidisciplinary care? And why should it never be neglected? An emphasis in never, because it seems that it's most of the time always neglected at some point. The reason is when we live with diabetes, we can very much have an impact in our mental health on regular and daily basis. For instance, depression is occurrence in 2 or 3 times higher in people who live with diabetes And the majority of these cases will remain undiagnosed or underdiagnosed. I don't know if you ever have had a case where you're trying to express how you feel to one of your healthcare professionals, and that's the least of their interest at the time. And depression should be dealt with. Depression should never be overlooked. And sadly, it's still today severely underdiagnosed. 1 in 4 people living with type 1 diabetes have high levels of distress, as do 1 in 5 people living with type 2 diabetes. It's well known, and today we have often talked about the fact that when we live with diabetes, distress might occur at some point in regards to the way we live with it, in regards to our self-care, in regards to affordability, in so many aspects of our lives. But still, why are we not talking about it? If actually 1 in 4 of us, when we live with type 1 diabetes, or 1 in 5 when you live with type 2, this shows everyone who lives with diabetes is going to experience distress at some point in their diabetes career. When I read this, I thought it was very important for us to listen to it. As I said at the beginning, no one ever said that to me. And that actually made an impact in my life. You know what? Because when it showed in me, when I felt it, when I see people I work with dealing with it, they say, I never expected this to happen. And when someone you're not expecting shows up alongside your care with diabetes, this can really impact the way you feel and the way you deal with your condition. Diabetes burnout is common, and most people with type 1 diabetes have experienced it at some point in their lives. I'm seeing chat box, we're saying this actually happens. And this is important because diabetes burnout happens because we're not being able to stop at some point when we're feeling distressed, because we're not talking about it, because we don't have a space talking about this. And again, this can really impact the way we feel and the way we relate. Moderate to severe anxiety symptoms are an indication of anxiety disorder, affect 1 in 5 people with insulin-treated type 2 diabetes, and 1 in 6 with type 1 diabetes or non-insulin treated type 2 diabetes. This is within the range of popular estimates. So we also, alongside not only depression or burnout or distress, we can also present anxiety. And I ask you, does this come up when you go to your appointments? Is this something we're talking about regularly? But I think it's also very important whenever we do have this talk, or at least in my case, I would love to see what you have to say. It is always or mostly just related to self-management. But burnout, distress, anxiety, and depression and diabetes are really not only related to this. As we have heard throughout today, and we will learn much more, it also has to do with other things. I think the past panel was amazing about talking about this next subject, which is stigma. Stigma is one of the big things that we're exposed to when we live with diabetes. When a parent has a kid with diabetes, it's not only about the people living, but also their caregivers, their families. And the stigma is one of those big things that can really take a toll and an impact on mental and emotional health. Language, the way we're talked to by our support system, our healthcare system, can also impact the way we feel. Financial stress, which is one of the big things, having access to insulin or not on a daily basis, and the lack of emotional access and psychological support. Because if think about this, I always think about this, if someone we knew is being attacked or stigmatized, has been someone's using language that is not empowering or that is hurtful towards them, is having financial stress and cannot access whatever they need to feel okay, wouldn't we want them to have at least the ability to have emotional and psychological support? But this does not happen. And this can also have a severe impact in the way we deal with our condition. This is why it's so important to talk about mental health, distress, burnout, because it's something that will happen to all of us at some point. And that is okay. But we do need the tools to be able to deal with it and be able to manage it. For instance, in regards to access, in a recent research, it was found that 1 in 4 people reporting use of less insulin than is prescribed over the past year, specifically because of cost. The majority responded that 56% rated access to diabetes medication and insulin as their most significant access issue. If 56%, almost 60%, and a quarter of this population have to regularly think about this most definitely not only will have an impact on their diabetes healthcare, on their physical health, but also on their emotional and mental health. Hence, it's vital that mental and emotional health becomes part of life with diabetes and treatment when we live with diabetes. Because there is no health without mental health. I think this is a popular thing that we're listening today. But I was thinking when I was practicing this, and I say, well, yes, there is no health without mental health for sure, but there's also no diabetes without distress. And this is something that we should be advocating for. Mental health needs to be a priority when living with diabetes and should never be overlooked, because we are now beginning to understand that how people feel affects how the body and functions and vice versa. And that should never be neglected. And that is why mental health should be a priority. Thank you.
All righty. So good morning or afternoon, everyone. It's almost the afternoon here in California in the US. Thanks so much for attending this really important session. I want to thank T1 International and my panel co-presenters for the opportunity to speak today. My name's Lauren Figg. I've had type 1 diabetes since 1998. My personal journey to advocacy really began in 2000 when my dad, who also had a chronic illness, unexpectedly passed away and we lost our health insurance coverage. This was pre-Affordable Care Act, and so we were denied health insurance coverage for a decade until the landmark legislation passed that required pre-existing conditions to be covered on health insurance plans. We all know the financial impact of living with diabetes, and I was really thrust into the advocacy world through this experience, just living one vial at a time for 10 years. I completed a master's degree in social work in 2015 and focused much of my research on what we're talking about today, which is trauma-informed care. I wrote a really long thesis on this, and I could spend all weekend talking about it, but I'm going to do my best to get it in just a few minutes and share kind of my personal and professional experience in a way that gives you some key takeaways on this really important topic. And then I've also asked T1 International to share a list of resources with attendees. So there's a lot of additional reading that can be done with this. I first want to start out by taking a moment to recognize and honor a fellow diabetic and activist, Erin Gilbert, who died in July. Erin was a mentor and friend to so many, including myself. Her work in activism around drug pricing and trauma-informed healthcare really paved the way for all of us to be here today. Erin had an advocacy guide and a blog that I'll share in the resource list, and I really encourage you to take a moment to look at both of those. She was an incredible human who faced insurmountable challenges, and she is deeply missed. So trauma-informed ideology really grew out of something called the Adverse Childhood Experiences Study that the CDC and Kaiser in the US conducted between 1995 and 1997. I'm including literature about this in the resources because it's really, really important. And I just want to encourage you to read about the study and its findings. It's still very relevant, you know, even 20 plus years later. In simple terms, the study showed that things that happen to us can impact our health and well-being as we age, which sounds very obvious, right? There's a lot more complexity to it than that. But I want to focus how on each stage of this pyramid here, we have opportunities to mitigate these negative health and social impacts. And that's exactly what a trauma-informed approach does. So trauma-informed care has 4 key components, and they're to realize the widespread impact of trauma and understand paths toward recovery, recognizing the signs and symptoms of trauma, responding by integrating knowledge about trauma into policies, practices, and procedures, and actively resisting re-traumatization. This is what we're going to focus on today. There are also these 6 additional key principles I don't want to glaze over this, but I have more information about each of these and their importance and the resources. So trauma-informed ideologies have been implemented in social service, healthcare, and behavioral health settings over the last 20 years. Much of the graduate research that I did focused on how communities can support trauma-informed change, but I believe we can really apply these principles to every aspect of our lives, including advocacy. I actually feel that advocates have an obligation to supporting trauma-informed principles in movement. So I'm going to share some ways that we can think about Insulin for All advocacy from a trauma-informed lens. The first is to realize, and this is exactly what Tolu and Danny kind of introduced for us, understanding that a diagnosis and life with diabetes is traumatic in itself. Other toxic stressors like insulin insecurity is additionally traumatic. And then it's also critical for us to understand and realize the impact of other complex trauma related to race and ethnicity, sexual orientation, gender identity, poverty, abuse, historical trauma, and then all of those things combined with diabetes. Another really important thing is that the insulin price crisis is active. It's happening right now. So many advocates may and are definitely experiencing this in many ways. So it's important for us to understand that and take that into consideration when we consider advocate engagement. And we also don't want to lose sight that storytelling and community connection are absolutely vital to disease management. So even though this is very challenging and active trauma for a lot of people, the connection with other advocates and a purpose in advocacy is really important. Recognizing, again, like Danny talked about, signs of diabetes distress, burnout, and depression, and then learning the effects of trauma and adversity on health and behavior. I think this is the most important one for our talk today, is the response to how we can respond to understanding that living with diabetes is traumatic and be trauma-informed in our advocacy. One very important thing we can do is create safe advocacy spaces that are inclusive, welcoming, destigmatizing, and non-re-traumatizing. One thing that happens a lot, probably all of us need to be called out on this, is that often we are, as diabetes advocates, can be stigmatizing towards other types of diabetes, like type 2, not include concerns of other types of diabetes in our advocacy. And so creating these safe spaces for people of different backgrounds and with different diagnoses is really important. Allowing for engagement options that meet the needs of advocates. So diversify the way that you allow people to engage in your advocacy. As Ian mentioned, I was the chapter leader in California. California is huge, it's almost a country. So the difference between Northern and Southern California is like 9 hours or more, right? So having only in-person events in one part of the state is not open and inclusive for a lot of people. So considering things like technology use with Zoom, options for digital advocacy, things like letter writing campaigns, and finding unique ways for people to be involved that allow them to participate in a way, again, that they feel comfortable with and is not re-traumatizing. Considering physical safety, if you're having in-person events, do you have things like low snacks or things that people might need in the moment to be able to take care of themselves? I think it's important for us to provide access to resources for things like mental health and immediate assistance for people with diabetes. Participating in intentional and reflective self-care. I was so thankful that Liz led us in the mindfulness and stretching activity, because this is something that we also have to do very intentionally as part of our advocacy in order to be able to effectively care for ourselves and help lead movements. Again, I really want to highlight considering how our advocacy impacts marginalized populations. So things like if a bill is up for consideration, what percentage of our population in our state, neighborhood, country, whatever, is this bill going to impact? How does it specifically impact people of color, people in the LGBTQ community, other people, or people with other types of disabilities, people who are living in poverty? All of those things have to be considered from a trauma-informed lens in order for our advocacy to be effective. And then providing education and support for diabetes distress. We now know that this is a shared experience for many people. And so again, normalizing that conversation and educating people that this is kind of part of it and what we can do to really support each other. And then finally, resist. We can use, again, this is resisting re-traumatization. We can use non-judgmental, appropriate, and patient-centered language, create psychological safety, and provide support, especially around storytelling. If we're asking advocates to come and provide testimony for a bill, at the Capitol in front of a bunch of lawmakers, what can we do as leaders and as the diabetes community to provide psychological safety and support around those instances that may be re-traumatizing, but are also really important to movement? And then encourage and almost demand that advocates and community members utilize trauma-informed practices. So if you're engaged in a conversation with advocates and you're noticing that they're not really being trauma-informed, or they're being stigmatizing, re-traumatizing, there's a lot of opportunities we have to intervene and educate and ensure that we can make these principles a part of our larger movement. There's no handbook or guide on how to be trauma informed. It is really a best practice. It's a business practice. It's just a part of the way that we can and should be doing things. So I know I went through that really quickly. It's a big, gigantic topic. And you might be asking yourself, where can I start? Recommendations are here. And I just really want to point out one thing, that one of the big takeaways of the ACE study was that even though trauma can have lifetime impacts, one positive adult in a child's life can mitigate or delay these impacts significantly. This was one of the most important findings of the study. So this shows the importance of connection and relationships, and that is exactly what we have here with this community. So thank you so much. I'm happy to answer questions, see a lot of notifications in the chat.
So scenario 2, this is a long one, but it's a good one. Daniel is a 16-year-old with type 1 diabetes. During his diabetes clinic visit, the healthcare team noticed a pattern of increase in A1C, which is an average blood sugar level. His diabetes educator reviewed his blood sugar logs and saw that the reading dates were inconsistent. He denied having any management-related concerns, but when he met with his endocrinologist, he admitted to often avoiding checking his blood sugar and winging it for insulin dosing, which he attributed to not wanting to deal with his diabetes right now. As part of the clinic's multidisciplinary evaluation, he met with his social worker. During this assessment, Daniel disclosed that he has been experiencing some anxiety and intrusive thoughts as a result of witnessing domestic violence between his parents when he was 9 years old. He reported that these thoughts and increased anxiety were newly triggered by recent attempts by his estranged father to reconnect with him. After meeting with a social worker and the clinic psychiatrist, he agreed to a referral for trauma therapy to discuss how this traumatic event and his current symptoms may be affecting his diabetes management, and to strategize on how to address these symptoms to improve his overall health. So what do you guys think? Is this a trauma-informed care? Thank you all for taking part. I see yeses, and that is right. It's a great example of trauma-informed care. Most people living with diabetes will experience a period of neglect for their management. It doesn't make them irresponsible. As a community, instead of labeling people with diabetes who are unable to stabilize their blood sugar level as non-compliant or bad diabetic, let's just seek to understand many potential psychosocial reasons why this could be taking place. Even if you haven't experienced traumatic event in the past, living with diabetes in itself is a traumatic event. And so communities, healthcare professionals need to engage with that understanding. So in conclusion, the opposite of trauma is safety. Many healthcare professionals, including diabetes clinics, have started integrating screenings of trauma exposures and symptoms into their care pathways. These screenings can include child and adolescent trauma screen, the SCARED, PTSD assessment, and life event checklist. Given the likelihood that many people in general would have experienced some sort of trauma in their life, events at some point in their lives, and as individuals living with diabetes, as allies, seeking knowledge and trauma-informed care can help in maximizing the well-being of patients, families, and so forth. This is a movement for all. Additionally, many communities do not have access to multidisciplinary teams and mental health care, such as trained psychologists, psychiatrists, and many other mental health workers. The presence of these key healthcare professionals can decrease the stigma of seeking care and make seeking help more straightforward. But all this again starts with conversation and a safe space and a nurturing environment to get started. Thank you all. And remember that there are always resources online, and always seek professional help where possible. And now, any questions for us?
I saw a question in the chat. Do you have any practical suggestions for reducing re-traumatization of advocates, especially storytelling in non-diabetic settings? That's a really good question. And I think that the biggest thing that we can do is prepare people for, that this is going to be challenging, right? If you're if you're doing testimony, like for a bill, the people are hearing that bill, the representatives may not have lived experience with diabetes and may not understand the intricacies of what it's like living with diabetes and experiencing insulin insecurity. And so preparing people as much as we can that you might have questions that are uncomfortable. You don't have to answer anything that you don't feel comfortable answering. And then providing follow-up support for that person immediately and maybe a day or two after. How are you feeling right now? Is there anything you need from me or the community? Is there something I can help you get connected with or talk through immediately? And then in a few days, now that you've had some time to think and sit on this, is there a way that we can be supportive to you? I think that it's also, we can be really empowering when we look for people to provide legislative testimony. So instead of directly asking somebody, maybe allow people to volunteer and give them some expectations about what it might be like. We don't have control over what those types of settings are going to look like or what the response will be, but we can really just like cushion the experience for that individual who is storytelling. And again, just providing constant support, I think is the biggest thing, and recognizing that it could be re-traumatizing is a really big piece of that.
All right, do we have any other questions coming through? And we will be sharing resources after this via email, and we'll get that out to you. And thank you all so much for listening.
Yes, thank you so much. And I just wanted to say, if we don't have any questions, remember that mental health is also a human right and should be. You all should know that whenever you're treated, you have the right to ask for help, and you should never be discriminated or judged upon it. And if you are, just ask for help. You should not feel by yourself or alone. And it's something you have a right to ask for.
Thanks, everyone.
Thank you so much.